Good evening, everyone. On behalf of myself, Kylie Booth, and my co-moderator, Howard Ovens, welcome to CAEP National Grand Rounds. Tonight, we bring you Learning to Surf Lessons from Wave 1, and this evening is part 2. So many of you joined us in September when we heard from Drs. Eric Latovsky, Mark Afalalo, and Kieran Moore, who shared wonderful lessons learned from COVID thus far, and really brought a rich context to what we may face as we start to enter wave 2 this fall. At this time, many of us are seeing rising case numbers, rising ICU occupancy, after a bit of a reprieve over the summer, where I hope many of you got some rest. We all know that this will be a marathon pandemic, and certainly that the show must go on for us in emergency medicine across our nation. Emergency medicine has been at the forefront of this pandemic, and we have learned a great deal about the virus itself, of the public health measures used to curb its spread, and about how to manage our day-to-day operations and provide high-quality care to our patients. We now, I think, have confidence in our skill sets, in our PPE, and in our supply chains. We all know that boarded patients, overcapacity hospitals, and ED gridlock have long been the Achilles heel for emergency department flow. Indeed, this pandemic has further complicated that mess. So tonight, we're going to turn our focus to individual flow and efficiency, some analysis and management in the time of COVID. We're going to bring you 3 dynamic speakers, which Howard and I are thrilled to welcome. We have Dr. Douglas Chisholm, Dr. Teresa Chan, Dr. Grant Innes. These are dynamic speakers. They're going to set the stage for what is happening across our country. And I hope to provide you some helpful tips on how we as emergency physicians can best navigate our performance in the face of this pandemic. CAEP has long advocated for our discipline, and since COVID has provided guidance documents, position statements, and hosted forums like tonight, the virtual town halls, to ensure that we're all connected and leading edge in our knowledge translation. And we are really grateful for their leadership in this unprecedented time. So without further ado, to introduce our speakers, please welcome my colleague and friend, Dr. Howard Ovens, Emergency Department Lead for Ontario Provincial Emergency Services Advisory Committee.
Well, thanks so much, Kylie, and good evening, everybody, and thank you so much for joining us. And I do want to take a moment to thank CAEP for creating this opportunity this evening, and more importantly, for supporting emergency physicians creatively throughout this crisis, and for in general giving emergency medicine a voice and a home in Canada. These days, we are too often reminded that democracy and its institutions only function as well as the engagement of responsible citizens allows. CAEP needs you to be an effective body. If you aren't a member, join today. If you are a member, convince a friend or a colleague to join us. Couple of plugs. Our next National Grand Rounds will be October 21st at this same time, 7 o'clock in the Eastern time zone. The topic will be the top 4 research abstracts. We'll hear from Ian Steele, Sheldon Cheskis, Brenton Wong, and Catherine Varner, and they will present the amazing abstracts that would have been presented in Ottawa at the research plenary if only the world had gone on as we had expected. I also want to give a personal plug for a conference I'm involved with, the ED Administration Conference, Canada's largest and longest running conference for emergency services leaders and future leaders. Like everyone else, we're going virtual this year, and the conference will be on the afternoon of November 24th, and I hope you'll look for it. I think it'll be of general interest. To save time this evening, we'll keep the introductions brief. All of our speakers' bios are online at the CAEP website, but we are truly lucky to have these experienced leaders here to share their thoughts with us tonight. First up will be Doug Chisholm. Doug is an emergency physician at 2 community sites in Southern Ontario, the Collingwood General and Marine Hospital, where he practices with Kylie, and at the Royal Victoria Hospital in Barrie. He's also a transport physician with the Ontario Air Ambulance Service Orange, and has a personal interest relevant to tonight's discussion in JavaScript programming, web development, and its application to clinical settings. Doug will hand off to Teresa Chan. Teresa is an associate professor at McMaster, but she holds several impressive leadership positions related to education and faculty development. She's well known for her innovations in education and education scholarship, including the use of web-based and newer technologies. She also created a game on emergency flow called Gridlock. Teresa will hand over to Grant Innes. I probably don't need to introduce Grant at all, but he's been an emergency medicine leader in Vancouver and Calgary. He was the founding editor of CGEM, and otherwise he's basically just a very famous emerge doc, well-deserved too. We'll hold all our questions until all the speakers have concluded. Doug, take it away, please.
All right, I hope you all can see that. You good? Okay. Evening, everybody. Thanks for indulging me tonight. My name is Doug Chisholm. I'm an emerge physician from Ontario. For the past couple of years, I've been teaching myself to code, and I've been exposed to the software development community and their culture. I wanted to share with you this evening some of the things I've picked up along the way that I think might be relevant to the practice of emergency medicine. Maybe some of them can help you improve your flow in the department. So first of all, I have no disclosures. There's no paid product placement here, unfortunately. So buckle up, we're going to move along pretty fast here. I want to talk about, quite honestly, the most marginal of marginal gains, and how a little bit about how emergency medicine is like coding. And then we're going to talk about some geeky hardware stuff and some nerdy software stuff, and a little bit about the end, at the end about learning to code. So I'm sure many of you have heard of marginal gains by now, and I wonder if the concept's maybe a little bit overplayed, but it was popularized by Sir David Brailsford, one of the most successful cycling coaches ever. And basically his idea is that small 1% improvements added together and multiplied over time allow for large improvements. For example, he had a surgeon come and teach his athletes how to wash their hands so they wouldn't get sick and derail their training or performance. So there is a COVID reference if we are keeping score tonight. So the next thing we're talking about, emergency medicine is a little bit like coding. And I got a lot of inspiration from a book called Automate the Boring Stuff. Plenty of what we do in the emergency department is boring and repetitive and time consuming. An ankle sprain is mostly the same every single time. And I shudder to think of how many hours I've spent documenting ankle sprains over the course of my career. I'm sure it's north of 100 hours I've written that same chart. The book on the screen there, Automate the Boring Stuff, is about Python. It's the fastest growing modern programming language. It's the de facto language of science, finance, and artificial intelligence and machine learning, if you're curious. So you can see the similarities here. Emergency medicine can be quite algorithmic. An if then else statement applies just as much to emergency medicine as it does to developing software. Quite honestly, you know, as much as I enjoy my job, there are days when this environment looks pretty appealing to me. All right, let's talk about keyboards. Let's be honest, we all spend a lot of time on our keyboard at work. We probably use our keyboards more than we use stethoscopes. This rather disgusting photo is a picture of an actual keyboard in an actual emergency department where I actually work in Canada. And I'm not gonna lie, I feel the same about those plastic keyboard covers as I do about home blood pressure monitoring devices. And I'm fairly confident that there's some COVID on that there keyboard. So if you're a fan of Reddit, you can find a subreddit there called Mechanical Keyboards. It's for mechanical keyboard enthusiasts. It's mostly computer geeks and software people. There's about 300, well, 750,000 subscribers, which always astonishes my wife. She can't believe there's that many people who care. Anyhow, this is my keyboard. And what's special about it is it's a mechanical keyboard, and it's different from the cheap, squishy rubber membrane keyboards you all have on your Macs. And it's like the old IBM keyboards from way back in the day. They have a little mechanical switch and they're built specifically for people who type fast. They have a click that gives tactile feedback and it makes a very satisfying clicky sound. They're easier to activate and they don't bottom, or you don't have to bottom out the key to activate the switch, which makes for faster, more accurate typing. And it will definitely improve your flow, keyboard warriors. So nobody would think less of you if you brought one of these to work. But I guarantee you, if you bring one of these bad boys to work, the cool kids in the department will definitely make fun of you. All right, let's talk about forms. I don't know about you, but I fill out a lot of forms. I always say I am a professional form filler. So you should not have to walk to the other side of the department to find your forms. You should not have to dig through a filing cabinet. The clerical staff in the department should not have to print one out for you just for you to fill it out before they fax it. You should not ever have to put your name, your contact information, your license number, your billing number, or the date and time on a form ever again. That honestly is what computers are for. So I started making my own fillable PDFs, which raised a few eyebrows and generated some pushback. And people always tell me that I should get somebody else to do it for me. And I always ask them, who exactly is that person going to be? It's really not that hard to do. I use Acrobat, or you can use Adobe Acrobat to do it. I actually personally use Power PDF. Acrobat costs $20 a month as a subscription. PDF is, or Nuance is a one-time only $100 charge. The other thing that's cool I've learned about PDFs is that you can actually build JavaScript into the forms so they can do their own special things. And I'm going to show you an example on the next slide of something you can do with JavaScript and PDFs.
Okay, so this is me yesterday filling in a Form 1. Anybody who works in Ontario is probably familiar with a Form 1. When I open it up, it becomes pre-populated with my name, the hospital where I work, all those other fields. I just hit date and time and it populates it with the current time and date both here and down here at the bottom of the form. No typing required.
So I know that's super geeky, but it only takes 4 lines of code to get a form to populate itself with the date and time. And of course, I had to build a little website to keep all my forms on because I didn't want to have to depend on the IT department. So the next thing we're going to talk about is text expanders. I don't know how many of you have seen these things, but they're voodoo. They basically work in the background and watch what you're typing in your emails or your EMR or a word processor. And when you type a trigger word or phrase, it replaces it with a larger snippet of text that you've defined. The two that I've experienced with are Phrase Express and Text Expander. Phrase Express is free and it works on your PC. Text Expander is not free, but it works on the Mac. And interestingly, if you use the mobile version of Phrase Express, you can install it on most computers at work without, even if the IT department has blocked you from downloading and installing programs.
Okay, here's something I put in a chart all the time about incidental findings on an imaging test. So if I pipe hashtag incidental, it replaces it with that whole blurb.
Okay, next up, let's talk about voice recognition software. I'm using, or I'm sure many of you have used this already. It's been a bit of a game changer for me. I'm using Dragon Medical One. The accuracy is really quite amazing. It understands medicalese, and you can train it to recognize special words, names, or phrases.
This is an example of Dragon Medical 1 in action. If you've never seen this voodoo before, I'm actually talking into my phone and the words just appear on my screen. After a year of using this, it still makes me almost giggle every time I use it. Note template. This 75-year-old gentleman came to the emergency department complaining of chest pain. Period. It describes it as a pressure. Period. Next field. Smoker. Period. AAA. Period. Next field. Atorvastatin. Period. Hydrochlorothiazide. Period. Next field. Afebrile. Period. Blood pressure 123/75. Period. Respiratory 18. Period. 98% of room air. Period. GCS 15. Period. Normal cardiac exam. Accept defaults. Normal chest exam. Normal neuro exam. Accept defaults.
The idea. I actually have pre-made templates for things like concussion and ankle sprain. If I say right ankle sprain note, it drops the full note and the exam with discharge instructions in the EMR. I've actually also started using templates as a CME tool. I recently added, for instance, the wobbler mnemonic to my syncope note to remind me of things to look for on the ECG. Provides for some spaced repetition. All right, last thing I want to talk about is learning to code. People always say doctors should hire someone to build their project because it's not a good use of our time. Maybe we shouldn't have learned how to do ultrasound. It's not really that hard. All the resources are available online to learn. You certainly don't need a computer science degree. And I would say if I could go back in time, I'd spend part of my academic year in residency at a coding boot camp. I certainly don't think it's for everybody, but I really think there's an opportunity for emergency physicians or a group of emergency physicians to carve out a niche where they're building something. So if you learn a little bit of front-end code, some HTML and CSS, you can build websites that display information. If you learn some fairly simple JavaScript, you can build web apps that actually do something. So here's a little website I built. I got tired of hunting for handouts that I give to patients along with their discharge instructions. So I archived the discharge instructions here. It's just a little bit of HTML and some CSS code. I'm sure many of you have used MDCalc. If you haven't, you should be. It's a super handy tool, and it was built by two emergency physicians who met while they were doing their residency in New York City. This is probably one of my all-time favorite websites, first of all, because it's so incredibly useful and I use it a couple times a week, but also because it's so simple and so elegant. It's basically just one page, but it does the job so well. I got tired of calculating how to bill for procedural sedation in Ontario, so I built this little app. And this one's a prototype for an app that I'm building. It allows you to text discharge instructions from a third-party number at the bedside to patients. And the ones that I've tried it out with seem to love it. So my main final take-home points would be automate the boring stuff, save yourself some brain bandwidth, and don't forget or don't wait for somebody to build something that you think will make your next shift go more smoothly. And that's it. Thanks for listening. If anybody wants to get in touch, you can find me at ERFaster, and I'll pass it over to Teresa.
Hello, everyone. Thank you very much for tuning into my talk. My name is Teresa Chan, and I am thrilled to be here on behalf of CAEP. I'm going to be talking about some of the work that I did during my Master's of Health Professions Education. and talking a little bit about knowledge translating some of the findings we had. And so at the beginning, like I thought, oh, what are all the methodologies that might best answer my research question? And I thought really, really hard about what that would look like, because I was just really inspired by the fact that when I started in residency, I could see one patient an hour maybe, and thought like I was a rock star. And then when I got to PGY5, I was bouncing around, flowing a whole department. I knew every learner, I knew every patient on the board, and I knew which learner was supposed to do what. And that level of really complexity was something that I was trying to figure out. And so I actually dove in to try to figure out what would be the best way to answer my research question, which was, how did we actually teach flow? How did I get from that lowly PGY1 who could barely figure out which way to go into the department to recess, and turn into someone who was able to file away all of this information. And with the guidance of some of my thesis advisors, like John Sherbino, like Jeff Norman, and Matt Lineberry, I actually was able to come to the idea that maybe I should just like talk to people and do some qualitative work, but then also observe them using some level of simulation to see how they think about it. And so that was really cool to do. Now, in terms of conflicts of interest, I have a bunch of different teaching obligations I need to declare for, accreditation purposes. But intellectually, I have a conflict of interest in that I am super proud of the board game that I created, and I'll be talking about it later. But the idea is that it's a game to help people understand how you flow the department. So that's an intellectual conflict of interest that I'll declare. And I want you to think about, just for like not even 30 seconds, because you're all in Merge Docs, I could probably do it for like 5 seconds. So think about, how do you learn to flow the department? And how do you teach about that now? So think about it for a second. Okay, file it away. We'll come back to that later. But to me, I repeated these things because I wanted to be a little bit meta. But the idea is that I learned to flow a department by repeating, and kept on doing it, right? There's something about deliberate practice with feedback that can get you to go from 0 to hero. And it definitely was a huge part of what I did. But I don't think that that's the only way to do it. And I think that there are a bunch of hacks that we can do. And so I'm going to be talking a little bit about all of the stuff that we found in our findings, and you'll be able to scan the QR codes. If you're watching this, you can pick up your phone and open your photo app and then just actually hold it up to the screen right now. And you'll be able to, it'll take you to a link that can open up the paper that I'm talking about. But generally speaking, what I found in some of the research I've done is that many emergency physicians don't receive training on ED flow formally through their training. They do get a lot of informal apprenticeship-based feedback, and they learn on the job. They do what I did, and just keep doing it and doing it, maybe getting some feedback along the way. And that is a great way to do some of this work. But at the same time, what it is that this is changing with the introduction of competence-based medical education in both of our training programs for emergency medicine in Canada. We are going to be asked to teach this skill. And so I'm really excited. Thank you to Howard and Kylie for seeing, that this is an important skill set. And let's talk a little bit about it. I'm going to give you some tips to be able to think about how you can teach this to new trainees along the way, but also at the very kind of more senior steps. And to be honest, what you can do if you're, in a community setting and you have a newbie that's starting with you on staff, right? Because let's be honest, when I started as staff, I was not the most efficient, but some of the tricks along the way that really helped was actually helpful for me to become better and faster and more efficient. So the first tip is I'm going to drop an analogy about chess. And really what it comes down to is that, like when you are in PGY1, you can imagine it, the analogy is like every one of these patients is a very complex chess piece, and you have no sense of which way the little horsey moves, and you have no sense that pointy hat, character on the board, where do they move, and how does the queen and king move, and what's this rook thing that people keep talking about, and you're just trying to learn all the pieces and understand. And of course, it's the chess analogy falls flat because it's not like we only have a couple of pieces. We actually have thousands of phenotypes of patients that we have to actually learn to combat. And so that is one of the things that I want to acknowledge is that, the traditional paradigm of how we teach medical trainees when they're very junior is that we teach them history, then physical, then investigations, then management, diagnosis. And yes, until you know enough about each individual patient, it's impossible for you to really handle multiple patients. But your job when you're very junior is to understand and know each piece so you can flow the whole department someday. And so the idea would be that when people are very, very junior, you want to make sure that they understand how each piece moves, and then they can start zooming out to see the whole board. So we got to start with the basics, which is they need to understand the dynamics of each individual patient, their story, their journey in the department. And that's actually a precursor knowledge that all the teachers that I talked to and then all the residents thought that were really important when we actually discussed and did qualitative analysis of their recollections. In terms of the second tip, and I'll say that a lot of the inspiration I had was sitting in a lot of coffee shops where you can still do that, and actually watching, a fast barista, an experienced barista that just like seamlessly flowed, managed multiple drinks at once, was always like flipping back to check the list, and then add 2 pumps of this, and then get something blending over there, and then setting the drip espresso and warming up milk and all that stuff. And they seem to seamlessly just like interweave all their actions. On the flip side, the slow baristas, the ones that were orienting, where someone was watching over their shoulder with a binder, and they're like, what goes in a frappuccino again, and what goes into a flat white? How do you make that? And a caramel macchiato. So like all of those things, people were actually thinking, I thought that there was something there. And to be honest, the analogy there is that that fast barista was cashing in on experience and foresight. And so the idea is that with experience, you start to chunk data together. So just like the chess masters, you see bins of moves. You don't just see one move, you see 3 or 4 moves at once. And as you become more experienced in the emergency department, you actually anticipate patient stories some more. And so my insight here is to be patient with your learners. They lack experience and they don't know the workflows. They don't understand that, if they pick up that chart with 15 minutes left in the shift, there's no way in heck they're getting that x-ray done. There's just like no way. And that, they should probably just simmer down and wrap up the patients they have, because they don't really have an anticipation of how long things take. And I think what we can do as teachers along the way, when you have a very junior trainee, such as a med student or a junior resident, is that we can actually give them feedback about those process measures and actually make that an articulated step. When you're talking about, oh, what do you want to do? And then name all the tests, they'll just say, order them. Actually, do you know how long it takes for labs to come back, right? And actually fold that into their learning. And because you call that out, and over time, they can start to anticipate that, oh, abdo pains take more time because we have to do, labs and investigations depending on the time of the day. We can get an ultrasound or a CAT scan, and all of those things are going in their head, and they're saying, okay, so I have time to see an abdo pain with 2 hours left in the shift. And those are the kind of things that you can set people up for success. So I think that experience is foresight, but I think also you can give them that experience by teaching them explicitly rather than having them figure it out on their own. And so I think like the fast baristas could probably have given the slow baristas some tips about how to anticipate that, you've got 3 non-fat mochas coming up. So why wouldn't you just make 3 sets of amounts of the same milk rather than doing it one at a time? Because that doesn't make any sense, right? So you can batch things, chunk things, and do all these things better. The third tip is that you can show your work. And just like in math class, when you were trying to actually figure out, how the equation worked, but then your math teacher would come along and actually just show their work in front of you, and you're like, wow, I get it now. And as soon as you went home, you had no idea. But the idea would be that sometimes if you show it really well and go step by step, rather than just flashing a PowerPoint slide, you can actually build the idea and then show the way that you're reasoning, thinking. And the best math teachers, the best chemistry teachers, they built the ideas in front of you. And I think that that's something that we can do. And it's called cognitive apprenticeship. And this is the model that can help junior learners transition to being more senior, and senior learners into staff. Because what you can do is you can acknowledge the fact that the learners are always watching you, first of all, that whether you like it or not, you're a role model. And what you can do is you can prime them, and you can ask them to observe what you're actually doing to manage the department. Even if you're not going to actually have them run the department, you can bring them in to like just spy on you, to see how you round on your patients, or almost religiously. The idea of how do you actually bring the nurses in to consult, how do you go up to the charge nurse, all of that stuff is actually important to prime them to watch you do that and to watch other people do it. Because once you ask them to watch you, they're going to think, oh, I should do this on other shifts. And I think that's really important, because then they'll be able to see how different people do things. And that's really an important part of the process of learning. And the other part that you can do is do something, a simple task, something called a think aloud. And the idea would be, just like math teachers, you're doing the hard work in front of them. And what you can do is you can basically when you're running the board, you can ask them to join you in thinking aloud about what you're going to do and see which your next steps are going to be. So they can actually see you basically showing them the work that you're doing implicitly in your head, but you're using a think aloud procedure. And that was a big part of my thesis. I sat and listened to a whole bunch of different faculty members and attendings talk loud as they were kind of prioritizing patients. It was really interesting to really get to the bottom of how people thought about these things. And it was a great privilege of my colleagues that they let me do that. And I think that we can use these techniques for more advanced junior learners and for those who are early senior residents. And to be honest, if they didn't benefit from this yet so far, sometimes you're junior faculty members and junior attendings. And I think that showing your work can be a really good way to kind of connect the magic of what you do with the reality of how someone can actually think through it. And I think the fourth tip is that you don't have to always do it to be honest, in the emergency department, because sometimes it's just so busy that you have to divide and conquer. You don't have time to do all the stuff that was been talking about. And so I think that sometimes you can be, when it's safe to do this again, barring social distancing rules, and maybe in some jurisdictions you can actually pick this up, but you can check out our game. And the idea would be that this is where you can have that bird's eye view and really talk about how you would flow a department. Who are you going to take care of first? Who are you going to move around? How are you going to make things more efficient for the nurses, for the doc, things like that. And you can have that conversation. And so Gridlock Game was a game that I created to really kind of give us a platform to be able to teach these things outside of the classroom. Because, we've used disaster simulations for tabletop simulations for mass casualty events for a long time. And that's a great way to kind of like think through disaster processes and maybe disaster planning for your jurisdiction. And so often EMS and fire and police and the hospitals will engage in these kind of desktop simulations. But let's be completely honest, every day can be almost a bit of a disaster in itself. So I thought maybe we could make a desktop simulation that would be similar to that. And so that's why we created this gaming platform. And so serious games are games that are meant to not necessarily be fun, but rather to teach something. And so although you can have fun as a side effect with Gridlocked, it's not the key intent. The key intent is to give junior learners a safe environment to make mistakes and ask questions about why you went there and why you prioritize this patient over the other. And for senior residents, it's a great way to kind of start stimulating a conversation around the different decisions that you have around how you would flow the patients, what you could do, what are improvements you could make, how would, having order sets of change the workflow, how you would deploy house staff, because there's actually a little resident that runs around the game and is to role play a junior resident. And that's the idea, is that you can actually have those conversations. And so I've used this in a multiple contexts, and you'd be surprised with a bunch of high schoolers. I played it with them and at a discovery day. And by the end of turn 4, if you had recorded the audio, you would have thought you were talking to junior residents at least. And so it's pretty impressive how quickly people can pick up the concepts. Now, making the jump between the box and the reality, that's something that you definitely need to take on with experience and things like that. So we've already talked about some of those techniques. And Gridlocked is just one of many simulations that can be helpful for this kind of thing, but it's one that's affordable. Some of the other ones cost a couple $100. Ours is under $100 American and about $120 Canadian. And so you can check that out if that's of interest to you. And it's actually not too hard to kind of pick up quickly, and there's lesson plans that are free online. And the 5th tip is that nothing beats real-time coaching. And so just like you would have with an Olympic athlete, if you wanted to up their game, and some of your senior residents might be at the level where they're kind of beginning to really show talent in this, you do need to give them some coaching and feedback. So one strategy would be to run the patient tracker with them. Another one might be to walk around as well and go through all the cases. So similarly, just run the board, run through all your patients. Another strategy is going to be directly observe and audit the resident's workflow. So like, flip the paradigm and let them run the department. You can kind of just give them notes and follow them around a little bit. That probably is employed best with a more senior trainee or junior faculty member or a junior community attending. Strategy 3 is to assign a resident a section of the ED and then check in and debrief with them to see where they're getting stuck, right? Another strategy would be to engage in collaborative problem solving for difficult situations. So to bring them to the front when you're actually being called to, figure out bed blocking, to actually go through if there's multiple incoming sick patients, what are we going to do? How are we going to solve this puzzle, right? And so engaging them in all of that. And so truly nothing can beat that real-time coaching, but we can maybe do some things to set people up really well to be able to absorb the lessons learned from the real-time coaching. And so these are 5 tips, right? So learn how each piece moves, and then they can learn to see the whole board. Help people to anticipate and learn to anticipate by actually calling out workflow as a part of the patient's whole story and journey. It's not just their differential, it's not just their diagnosis. Management it increasingly includes that awareness of the workflow. Show your work, engage it, allow your residents and trainees to engage in cognitive apprenticeship. Think inside the box with using simulations of serious games. And then, of course, we have to acknowledge that nothing beats real-time coaching and the game time experience. All right, so if you want a summary of all of that in like 2 pages, we wrote an article for CDM, which is at this link, which is just the facts, and you should be able to access it right now if you're a CAEP member. So definitely look forward to kind of seeing things from your perspective when we do some questions and answers. And I'm going to kick it now over to Dr. Innes, who we all know requires really no introduction, but he's going to be taking us through some really cool thoughts on his own. So I will take it away, let him take it away.
Okay, let me just, there it is. Okay, now, I hope people are seeing my screen. I'm not seeing it. Good. Okay, excellent. So a few weeks ago, Howard asked me if I could give a presentation on COVID and operations. I was already gathering data on the COVID pandemic in BC and Alberta, so I thought I would just combine the information and present data from the West, which is a region of about 10 million people. I gathered information from Health Canada, from PHAC, and the relevant health regions, and so that's what I want to show you today. Before I start, I too have a disclaimer. I live in BC, so I'm very forward thinking. But I grew up in Alberta, and despite this unfortunate upbringing, I do believe in hand washing, masks, and social distancing. But I think we made some mistakes in this pandemic, and I hope that we can learn from them. Okay, what you'll see when you look at the data, things are really different across the country, but I think the West is a good study because we're kind of an intermediate case. We're doing better than Central Canada, but worse than the Prairies and the Maritimes. If you look at case counts, and this is what I see on the news every night, you'll see that BC is the best place on earth, while the rest of the country is pretty much a basket case. But if you look at the fine print, what you find depends on how hard you look for it. And you'll see that as of a week ago, BC had done about 1/3 of the testing that the rest of the country had. So if you have different testing numbers, different testing strategies, case counts tell you nothing. That's my opinion. If we're interested in effects on the population and on our health system, we should be focusing on hospitalizations and deaths, which tell quite a different story, although they still show quite marked variability across the country. And this means that my comments today may need to be interpreted a little bit differently by people in different regions. Okay, now, so back in March, I became annoyed at how quickly they were shutting down surgeries and closing hospital beds. I warned you, I'm from Alberta. And to try and figure out what drove those decisions, I looked up some of the modeling data from a few months ago. This table comes from PHAC. What it shows is a predicted impact under 3 scenarios, assuming that we're taking all the measures we know about to flatten the curve. I don't know if you can see my little arrow, but I can see it. And so if you look at the middle severity estimate, with a 25% attack rate, that's the black column in the middle, we'd expect 250,000 cases per million, with 25,000 hospitalizations, about 3,000 deaths. If you take the best case scenario, a 10% attack rate, you expect about 10,000 hospitalizations per million population and about 1,200 deaths. So that means in a region with 10 million people like BC and Alberta, the middle case scenario, if we look at that black text, we would expect to see 250,000 hospitalizations and about 30,000 deaths. And if we look at the best case scenario predicted, we'd expect to see about 100,000 hospitalizations and 12,000 deaths. But we didn't have 250,000 deaths or hospitalizations and 100,000 hospitalizations. We had 1,500. And we didn't have 30,000 deaths or 12,000 deaths. We had 498 deaths. And that's actually about 1% of the normal background mortality for these 2 provinces. So these estimates, not too close. Okay, a few months ago, CMAJ published a great computer simulation which looked at population characteristics, attack rates, population behaviors, and they even tried to estimate the proportion of patients who would self-isolate when they developed symptoms. They then ran thousands of computer simulations and tried to predict how many hospital beds each province would need available when COVID patients started flowing in the door. And so again, I've taken their middle estimate, and this modeling says that Alberta and BC would both need about 48 hospital beds available per 10,000 people. So for a region of 10 million, that means we'd need to have 48,000 beds available. And they actually estimated more specifically about 24,966 beds available in BC and a little over 21,000 available in Alberta. Now, what actually happened, the numbers in the bed numbers, so these graphs show on every day since the pandemic started, what was the total number of people hospitalized. So in BC, rather than peaking out at 24,966, it peaked at 146. In Alberta, rather than 21,000, it peaked at 112. So these estimates look like they're out by a factor of about 200. Okay, so I'm looking through the retrospectoscope, and that's not fair. If I was, a few months back looking at Italy and Iran and seeing Canadian predictions of hundreds of thousands of hospitalizations and tens of thousands of deaths, I think our decision makers did what they were supposed to do. They were very cautious. In March, both provinces started by closing about 25% of our acute capacity, mostly by canceling surgeries and moving ALC patients. So this first step opened up about 5,000 beds to be available when COVID patients arrived. For a variety of reasons, both provinces overshot and ended up not at 75% occupancy, but down around 60% occupancy, which meant about 8,500 empty beds between the two provinces. So that's well below the predicted 46,000 beds they needed. But as it turns out, it's still about 200 times more beds than it turned out that they needed. Okay, now this is a graph showing ED volumes, what happened to emergency department volumes going through February and into March when you start seeing the effects of COVID. And oddly enough, what happened is the numbers, instead of rising, ED volumes fell off a cliff. They were down by about 50% overall in the West. They were down 70% in rural departments and urgent care. So people had been told not to go to the ED. They were afraid to go to the ED, so they didn't go to the ED. This is a little more detailed. This looks at community hospitals and academic hospitals. And so ED volumes were down almost 60% in community EDs and almost 50% in academic EDs. This graph shows that not only did ED visits drop, admissions dropped by about a third. So the graph on the top shows the baseline and then about a 1/3 drop in the actual number of admissions per day. If you look at admission rates, they went up a little bit because so many low acuity patients had disappeared from the emergency department. So admission rates went up, but the absolute number of admissions was actually way down. And what this slide shows hospital occupancy. So it shows you the number of hospital beds that were occupied. You see that in the community hospitals and academic hospitals, you went from a situation of over 100% occupancy down to a situation where you're probably 55 to 60% occupied. So huge numbers of empty beds just sitting there kind of waiting for COVID patients to arrive who, at least in the West, never arrived. The nice thing was that lots of patients actually flowed out of emergency departments. I saw lots of happy emails from emergency physicians who noticed that they were seeing patients in stretchers and that admitted patients were actually leaving the department. But there are some unintended consequences. So our kids have left home, and so at the end of April, we were kind of getting lonely, and we bought a COVID puppy. Our puppy is, as you can see, is a voracious reader. He always wants to help out around the office, so I've trained him to shred any confidential documents that he finds. Now, when you have a puppy, you have to take them for walks. One day, I think probably May, we were out for a walk. We ran into our friend Annie, who we learned had a recent breast cancer diagnosis. She was fairly upset at the time because in the middle of her treatment course, her radiation therapy was canceled, as were all of her follow-up visits. She was asking if I knew anything about the situation in Alberta. She was looking for somewhere where she could go to continue her cancer treatments, but everything in Canada was pretty much shut down. I don't know now whether she's managed to restart her treatments, but one of the unintended consequences of closing down huge amounts of your capacity is people aren't getting their surgeries, they're not getting their cancer treatments, and all of the care that we're not delivering doesn't go away. It's a debt that builds up that we have to pay down the road. So in mid-May, Alberta Health Services announced that it was going to reintroduce elective surgeries and that there's 80,000 patients waiting. In BC, I've seen numbers ranging from 30 to 93,000. BC says it might take a couple of years and 260 million in extra funding in order to catch up for what happened when we closed that capacity during COVID. So I hope that we learned some things here. in my mind, there are clearly benefits to travel restrictions, quarantines, and distancing. Even Albertans can see that. But there's really no benefit to withdrawing patient care and leaving huge acute capacity empty. There's health costs, monetary costs, and this has to be paid back later. I would accept that 3 months ago we didn't know better, and I guess I would summarize what happened by saying that I think smart, well-meaning people did the best they could and reacted cautiously in the face of what seems like pretty bizarre predictions. As somebody who spent a huge amount of time trying to figure out how to improve access for patients, I hope that we learn something from this and that we don't react with a sledgehammer during the second wave or in future pandemics. As emergency physicians and especially as emergency leaders, I think if we see the system shutting down around us, we need to ask some questions and advocate for maybe a slightly more cautious approach. And I think that's all I had to say, and I have to hand it back over to Kylie if I can figure out how to do that. I don't see the share screen option here anywhere. Oh, there it is, sorry. Got it.
Thank you, Grant. I don't know, can everybody hear me now?
Yes.
Great, great. Thank you, Grant. Thank you to all our speakers. That was amazing. I was expecting a lot and you surpassed my expectations. So thank you so much. I got homework to do. Anyway, we encourage you to drop your questions and follow-ups in the chat box. Christina will be moderating those and sending those along to our attention. I do have a question from Tony Brills. Tony, I'm not sure from where you work, but he wanted us to ask the panel a general question, and perhaps we can, we'll go in the order of speakers. So Doug, you can pass to Teresa, who can pass to Grant. If you were to pick 3 things to improve efficiency in the ED, maybe you could each pick one of your top hits, and that's from Tony Brills. Over to you, Doug.
Sorry, I just had to find my unmute button. I would say automate as much as you can. Don't duplicate work. Don't do the same thing over and over again. If you can have some piece of technology do it for you.
I guess we're all doing one. So I think for me, we should probably be teaching the skill more explicitly earlier. And we should be carving out a path for people to be successful so that just like they would with learning how to resuscitate someone, they're also learning how to save us from, bed block and other kind of challenges that are a part of our job now. And over to Grant, I guess.
Okay, I would say we have a lot of time-honored processes in emergency departments that we have to question. So when patients come in the door, they need to wait to see a triage nurse, they get triaged, they wait to see a registration clerk, they wait, somebody moves them hopefully to a care area, they wait to see a nurse and get some checked in, then they wait for a medical student, they get examined, they might wait for somebody else. And this is kind of an artificial sequence of cues, and I think the best thing that we can do is get physicians and decision makers move to the first step or the second step in the process. And the faster you get a physician or a decision maker, somebody who's going to make a disposition or order the right tests to the patient, the faster the patient and that decision maker meet, the better your department's going to function. And so at one extreme, that might mean sending physicians out to the waiting room, but at least it means getting the physician there as fast as you can.
Awesome tips. Howard, do you want to volley the next question here?
Yeah, we received a question for Grant. You talked a lot about which patients and how many of them were in hospital. Which patients stayed home?
Okay, well, that's the biggest drop in patients, as you'd expect. The biggest proportionate drop was in CTAS 4 and 5. So there was like a 60%, 65% decrease in CTAS 4 and 5. But because 4s and 5s make up a relatively small proportion of the case mix, it was actually CTAS, the biggest absolute drop in numbers was CTAS 3. There's some interesting things when you look at the types of patients that didn't show up. And the biggest drop was in trauma and orthopedics. So it seems like somehow about 60% of the people who had intended to go out on their downhill bikes didn't do that. And so we saw huge drops in orthopedics and trauma. The most preserved chief complaints, interestingly, maybe not surprisingly, were mental health and substance misuse. So I guess under the stress of COVID, people with mental health and substance use problems didn't do that well.
The two dueling public health disasters, a pandemic and a opioid crisis.
Right.
I'm going to pose one more question. I think we have time for one more.
Yep.
So we heard some great tips from Teresa and Doug, and also during the question and answers from Grant about flow. They were pretty generic. Can you name something you've altered because of the restrictions that the pandemic has imposed upon us, that you've done differently, or new innovation that you've introduced to be efficient with all our PPE and everything else that we have to do now for anybody?
I guess I could start, and I think I'm moving more towards like a one-touch approach where you see the patient, and if it's possible to disposition them or give them instructions and get as much done as you can with one visit, and not having to go back in and re-examine or rediscuss later. I think that's something that's potentially helpful.
One tip that I found from some colleagues that really helped with that is getting the patient's cell phone number and calling in rather than getting dressed and undressed every time you need to touch base on a question.
And theoretically, I think whenever possible, these people, you have to get them out of the department, and just to debulk just move them out. And yeah, like you said, cell phone or text communications is probably good for lots of them.
Yeah, I think that one of the things that I've been trying to do is involve the learners, but be efficient about that. So making sure that that you do give a chance for the senior resident to learn how to run the department, but that they don't have to, go in and see every patient with the med student. And I'll go see the med student patient with them, so that only one of us has to don PPE, right? So I think you have to be a little bit more frugal with the PPE. So instead of having this entourage that all goes, junior, then senior, then attending, I think we have to divide and conquer a little bit more. It's not to say that the senior resident doesn't get read in on the findings and other things, but they take more of a junior attending role, and then I can go a follow around the junior like a little puppy, like Grant's puppy, and be there for them. So we can isolate the skill that they need to learn, which is to run their department.
Anything to add on that one, Doug?
I just tried to batch some of my documentation and take some time away from actually being in contact with patients and being in a separate area to do my documentation all in one big go, as opposed to sort of in sequence while I'm actually looking after patients.
And Doug, have you replaced your stethoscope with your keyboard? Is the stethoscope dead?
No, be nice.
You still bring them both?
Oh yeah, I still bring them both, but.
Excellent. We're coming up to 8 o'clock, and I know people need to make their popcorn for the U.S. Vice presidential debates and make sure that they have things to throw and, they're adequately restrained on their couches for what promises to be pretty exciting. I just want to thank again our speakers tonight. This has been a wonderful evening, and I've learned a ton. And I have notes to myself of things to follow up on, as I'm sure all of you listeners do as well. And I think that is more than we could have asked for. So thank you so much for the time you took to prepare your talks tonight, your slides, and the amazing tips. If I'm going to take away some, I just to get involved with my IT and not be so scared about it. I'm not sure that I'm going to be a Python language speaker by the end of all of this, but certainly to use some of the text expanders, some of the dictation tips from Doug is great. And Teresa, I just loved your cognitive apprenticeship. Think out loud, share your thoughts with your learners, and how important it is that we teach flow early on. And certainly they can rest with Tintinelli at night, but the one opportunity that they have to learn that is certainly with their attendings. So thank you for that, and Grant, a wonderful high level look about what we saw, and I think a call to action for all of CAEP to certainly lead the charge in our just-in-time preparation capacity adjustments that we'll need to make, and make sure that our neighbors who have breast cancer aren't falling through the cracks as we move through this marathon that will be COVID over the months to come. So thank you so much to all of you. Thank you, Howard, my co-moderator. I'll throw it over to Howard, who can wrap us up and say goodnight.
Well, I'm just going to add my thanks to everybody who tuned in tonight for your attention, for your work in your emergency departments and your communities. And I got a great tagline this week from a patient, actually, who ended an email. Instead of just saying stay safe, she closed with stay positive, test negative. So I think those are good. That's good advice for all of us. Thanks, everybody.
Good night, everybody. Thank you.